Is okay. I'm going to start recording and get going just because it's 12:15 already. Some quick reminders, be sure that your audio is working and an appropriate level. Please keep yourself muted. The chat feature is a great way to ask questions, but I believe Dr. Bernstein will allow for some Q&A at the end. If you have technical difficulties, it's best to just sort of log off and sign back in, and generally that takes away any of the issues. We are recording this and it will be posted to the Butte-Glenn Medical Society YouTube channel in about 48 hours. Please give me a chance to get that done. And thank you to the Enloe Medical Center for CME. There will be a follow-up email for everyone. CME is not available for the recorded version, so I just want to be clear about that as we are recording this. So I'm Christy Bird McKeeve, the Executive Director of Butte-Glenn Medical Society. We are celebrating our 75th anniversary this year. I'm also the CEO of Healthy Rural California. It's a new 501c3. We got our IRS approval last January. We've already managed to acquire more than $2 million in grant funds in that 1-year period. So it's a really exciting launch of Healthy Rural California, which can also be the home of a future GME consortium, which we're currently building. I wanted to mention that Dr. David Alonso is the president of Butte-Glenn Medical Society, and he just joined. We also have a couple of the board members on the call as well today, so thank you for joining us. Today we have Dr. Bernstein. He's going to be talking all things COVID and was letting me know before the call started that there were 2 breaking news items this morning regarding the pandemic. So this is a well-timed presentation. I tried to summarize Dr. Bernstein's bio in this slide. It doesn't do any justice. He's been literally all over the globe and doing a lot in public health. Interestingly, he's been an adjunct associate professor with Emory University for many years. Before coming to Butte County, he was with Tuolumne County. He's been an international health specialist at more countries than I could name. And he got his career started with the CDC Global Health Department. So with that, I'm going to stop sharing my screen, and Dr. Bernstein, that is your cue to share yours. Welcome, everybody.
Thanks so much, Christy, and everybody for joining me today. I am gonna cover a lot of material, and I'm sure I won't cover all of it, or maybe even several important parts of it, as well as you folks may wish. But I'm including links to all the materials that I used to prepare this in the presentation, and I will make that available. Understand that the session is being recorded, as Christy said, and it'll be on the Butte-Glenn YouTube channel. So you'd be able to go into more detail on any of the subjects that I try to cover. So let's get started. How do I move the, can I close?
See the cursors in the lower left corner.
There you go.
Be a little bit faded out.
Okay.
Just click
so are you seeing my screen? Okay.
Yes.
All right. So, and how do I move the black thing at the top? Can I take that away too? The thing that has all the controls. Can I close that somehow? Never mind. It's okay. So I'm showing the outline of what I plan to cover, and I'm also gonna. Okay, so we're going to be talking about very briefly about the fact this is a global pandemic and the fact that it is a pandemic. It's been 100 years since we've had something like this with severity that we're experiencing. I'll be talking also about what this response is in Butte County with the partners, that all of whom are online. I'll be basically focusing on a recent CDC MMWR paper that described 10 evidence-based effective interventions, which if could be implemented as a multimodal program, would have and would continue to help us to control the COVID pandemic. And then I'll address some of the challenges that have come up in questions that people have asked in preparation for the seminar. The main challenges that I'll talk about are those having to do with the vaccine supplies, the allocation of the vaccines, and hesitancy about vaccines, specifically on COVID, but in general, which worries me very much about children's vaccines and those for adults as well. And then I'll say a little bit about what we know and mostly what we don't know about the variant strains of the virus. And the learning objectives, which I'll try to cover, really have to do with updating folks' knowledge. The amount of literature that's come out about the virus and a variety of related topics is just outrageous. You can't keep up with it. It's not possible. But I'll try to cover as much as I can. I'll aim for increasing attendees' knowledge about trustworthy sources of evidence and information about the interventions that I'll be covering. And I'll say something about how a provider who might be interested in being able to administer these vaccines can go about working with the state and through the state to the county to become registered, enrolled as a provider, get the training and become enrolled as a provider. And I want to certainly emphasize that the providers who are attending be vigilant to respond and report to adverse effects. That's going to be one of the breaking news items today. And then finally, I'm hoping to strengthen everybody's intentions and abilities to follow the recommendations that come out of authoritative, trustworthy sources like CDC, the California Department of Public Health, and the Butte County Department of Public Health. And that's what I'm aiming for. So this, I wish I could take that black bar away from the top because I can't see the top of the slide. But if I remember what the top of the slide says, is that this has been an amazing year in science. And I'm not going to spend a lot of time on this, but Nobel Prize winning work enabled scientists to develop vaccines for COVID-19 in record time. It had nothing to do with warp programs. It had to do with 10 or 15 years of work that had been going on about mRNA vaccines. And so I'm not going to spend a lot of time on this, but there have been an enormous amount of research leading up to the testing capabilities that we have and the vaccine and the therapeutic modalities that are available now. So before getting to California and Butte County in particular, I just want to say one word real quick about the false idea that Sweden tried to implement on the assumption that by allowing young people to get sick with COVID, they would protect everybody else in the country, and that young people wouldn't have severe effects. And as you can see in the chart here, this hasn't been updated, but I believe it's still correct, that the US leads the world, but close behind is Sweden, which has reneged on that natural immunity, herd immunity approach that they started, but they've stopped that now. So a couple of cartoons. I don't mean to make fun of anything that we'll be talking about, but schools, workplaces, everybody, I understand, is having a bit of cabin fever and COVID exhaustion, I think people have called it. But we are moving ahead. We're going to see the end of the tunnel at some point, as Dr. Fauci would have said. One of the remarkable things for me, Christy mentioned that I worked overseas for most of the 30 years or so. One of the remarkable things for me is people from Indonesia and Bangladesh and Afghanistan are calling me or emailing me and saying, "Are you all right? Are you okay?" When usually I would be calling them to find out how they're doing. So we're not doing so well in the U.S., but I think we're going to be doing better. Here's the situation and the trends in Butte County. We're all concerned about the fact that the surging, as you can see in the cases that took place here when a lot of college students returned during the summer and again during Thanksgiving and most recently as we go through the holiday season, the trends in cases and the trends in deaths are clear. What's also clear, as you'll see in a couple of slides, is the problem that those cases and the illnesses associated with them and the deaths are causing our healthcare facilities to become overwhelmed, as has the health department, and I'm sure a lot of you in your practices. So who's getting infected? The bulk of the infections, if you will, are in relatively younger people, but the deaths, not surprisingly, because of the severity of the illnesses when they do occur, have been mainly among the older individuals in the county. In terms of where the infections have been occurring throughout the county, it's everywhere. These are not rates, these are numbers. So Chico, of course, is the most populous area, so it's not so surprising that it has the most numbers of cases. But the fact is that infections are taking place everywhere in the county. This is one of the breaking news items this morning. Dr. Tomas Aragon is now our new director and state health officer. And he's absolutely fantastic. And one of his first actions out of necessity has been to issue a public health order to try to ensure that people requiring hospitalizations and intensive care will be able to get that care if it's possible and necessary, and if the facilities in the state are willing to work together to allow transportation under safe circumstances between facilities. As you can see here in Butte County, 7 of our 9 SNFs, skilled nursing facilities, are in outbreak mode at the moment. So it's no surprise that this problem is affecting the most vulnerable people and the elderly people in particular. This is a busy slide. I apologize for that, but I just wanted to put a couple of the data pieces on one slide. In the lower left-hand corner, as of the 5th of January, the greater Sacramento region, which includes Butte County, had less than 15% availability of ICU beds. That's changing on a daily basis. I actually didn't check for today, but I believe we're still under the 15% threshold for the stay-at-home order. And you can see from the, I don't know if you can see on this slide, but when you get the slides, you can look at them more clearly. You can see, for example, let me make my little arrow. How do I do that? Let's see, pointer options, laser pointer, pen, how about that? So you can see over here, one of the measures is the adjusted case rate. And we're just about every county and city in the state is in widespread tier right now. The criterion there is more than 7 per 100,000, and we're at 44.8. Here, why isn't that? Oh, there we go. Okay, and the other criterion is the testing positivity rate. That's over here. And we're at a testing positivity rate. Where are we? Testing positivity rate of 12 and 8 is the threshold. So using these criteria, our county and virtually every county, nearly every county and city in the state are in the widespread transmission mode of responding to the epidemic. So what kind of impacts has the pandemic had in Butte County? And you can see here that so many of our businesses, our schools, our own personal lives have been affected by the pandemic in the county. The stay-at-home order is in place. We were hoping that the vaccines, and we'll be talking about that later on in the presentation, will be helping to address the problem and allow us to get back to work, to school, and operate our daily lives. I'm lucky because I have 15-year-old triplets. They're smart, they're getting A's in teleschooling, but I'm lucky as a single dad because I can trust them to be at home taking care of themselves and doing their schoolwork while I travel from Chico down to Oroville to the office. But I can appreciate that if I were a single mom or a single dad in a house with one child, a young child, or a couple of young children, this would not be an easy time. So the Centers for Disease Control released an MMWR just a couple weeks ago. The link is here on the bottom of the bottom right-hand slide. And that paper is the basis on which I'm going to cover most of the things I'll talk about. There are 10 evidence-based, and by that I mean, and I'll give some examples, there's evidence from research, from observational studies, from laboratory studies and so forth, that these 10 interventions individually are effective, but collectively in a program would enable the US, the state of California, the county of Butte, and each of our cities to get back to work very quickly. Unfortunately, not all of them are adhered to individually, and certainly collectively, it's been difficult to try to get all of these interventions implemented appropriately and comprehensively and across the population. So that allows me, before I get into those 10, to just mention briefly and provide a couple of links about the important role that each of us as providers plays in addressing the myths and the misinformation and the disinformation that's out there. Not an easy task, closely held beliefs and values that are contrary to evidence and information, not easy to overcome. But I encourage all of us to have conversations with people who don't share our perspective, try as hard as we can to change their behaviors. Those behaviors have been demonstrated to adversely affect transmission and spread of the pandemic. This is just one paper in which community-based information in Winnebago County, Wisconsin, was used to study the beliefs and attitudes of young people in particular. Remember the size, the magnitude of the young people affected in Butte County compared to other age groups, but just illustrated that when the political decision-making was to stop the safe-at-home order in that county, based on the beliefs and attitudes of the folks, young people in particular, the epidemic just took off in that county. You can follow that information and look at more detail about which beliefs and attitudes were helpful and which were not, if you have time to look at that paper. Okay, so intervention number 1, the universal use of face masks. Ladies and gentlemen, masks work. What did Dr. Redfield do when the Congress held up the mask and said, use this? They work. The evidence is so clear that they work internationally, nationally, and wherever it's been studied. The consistent, appropriate use of masks is an effective means of reducing the source transmission from an individual who's infected to those around us, but also to a certain extent protects the wearer from exposures of airborne viral particles. So please, everybody, wear them and encourage your family and friends and patients and so forth to wear them. And that's going to include the time after you get your vaccine until we have 80% or so of the population of Butte County in California and everywhere vaccinated with the appropriate number of doses of vaccine. And we can see evidence that the vaccines are working in large scale as they did in the trials, and that their effectiveness is sustained. So lack of consistent mask use, this is just one of a number of those studies that I mentioned that have shown so clearly that masks can help, and that the failure to use masks, for example, in a gathering like a wedding reception, led to outbreaks and deaths. Ladies and gentlemen, masks work. And the same thing has been seen in Massachusetts General Hospital, where a cohort study was used to study the influence of wearing masks among healthcare workers in order to protect them during their work. It's just so clear that these masks do work. Again, another community-based study, observational study, but strong evidence that consistent, appropriate use of masks in the community can help reduce the spread of the infection. Physical distancing. I'm not going to say social distancing, because what we're talking about is not social distancing. My kids are taking their schoolwork on the internet. We use all kinds of information technologies to be in contact with each other. There's even e-dating going on. So it's physical distancing that will help limit the contacts and transmission of disease. And again, the links that are in this presentation all have evidence that has been used to document the importance and the effectiveness of physical distancing. Here's one study, choir practice. One symptomatic person led to a huge outbreak of individuals infected, because in that gathering there was singing, which is broadcasting virus, loud singing, and so forth. So one piece of evidence. Another piece of evidence, schools. It's much more likely that children will get infected in the community or infected from their parents who've been in the community without wearing masks than in a supervised school setting. The problem, of course, is that maintaining a supervised setting in the schools is not easy with respect to the use of masks and physical distancing. But if carried out consistently and appropriately, the evidence is that schools could operate with a careful program of non-pharmaceutical interventions, among the 10 that I'm going to be talking about, and supervision and testing, one of the interventions. So number 3, avoid non-essential indoor spaces and crowded outdoor spaces, outdoor settings. Again, the links here will lead you to studies that have provided the evidence and information about this is a hazard. Of course, it affects our economy. Of course, there are problems that have led for businesses to close. One of my favorite coffee shops in Tuolumne County and Sonora has closed. I'm sorry to know about that. But to reduce the risk, some restaurants are providing takeaway service and well-ventilated open-air dining. And it is possible to use masks and physical distancing when it's impossible to avoid having to go to an indoor space like a food market when you're shopping or whatever. But again, evidence and information is clear. The outbreaks that took place for example, in Minnesota, this outbreak was documented with molecular genomic testing. And it's clear that the gathering was the basis for an outbreak after a 10-day motorcycle rally. And 86 Minnesota residents developed COVID disease after getting infected during participating in this gathering by being close to each other. We've seen that in political gatherings recently. One more example, close contact and intense physical activity can contribute to the spread of COVID. This was an indoor sporting event, hockey event, and it's clear that it served as a super spreading event because of the failure to use masks appropriately and enabling in a gathering for this problem to occur. So widespread transmission of SARS has been documented in choir practice, meat processing plants, fitness, dance classing, squash facility, all kinds of gathering settings that didn't use implementation of non-pharmaceutical interventions. Number 4, there's a need for increased testing in order to diagnose the infections, isolate the cases, promptly investigate and report outbreaks when they occur. I mentioned earlier, we've got 7 outbreaks in the 9 SNFs in our county. The problem is that at least 40% or so of persons who are infected could be asymptomatic and yet be able to transmit the infection to others. So there's a need, especially in certain settings where it's known that transmission is a high risk. It's important that in those settings, there's testing, systematic testing. These are congregate settings for the most part. For example, the SNFs, long-term care facilities, perhaps an occupational setting, in congregate prisons or jails. This is another area where outbreaks are occurring, and there's a need to address this problem, in part by testing. So Cal-OSHA and CDPH, California Department of Public Health, have come out with a rule, AB 685, that requires workplaces to report outbreaks when they occur, so that there can be partnerships to try to address that with the help of local health departments. The Safe Schools for All program is another place where potentially testing now with rapid tests from antigens, if appropriately used as described in the emergency use authorizations and the package inserts, can be used for screening, for surveillance, and for response testing as well. Again, the links for these methodologies are here. This is just a chart that describes the differences in the usefulness or utility or appropriate use of diagnostic screening versus surveillance, diagnostic testing, screening testing, and surveillance testing. In Butte County, we have a number of testing sites available. There's testing guidance from the Centers for Disease Control. Some practitioners have made the mistake of using antibody tests. Antibody tests are not an appropriate means for diagnostic testing. They are at this stage, when the vaccinations become widespread, antibody testing will certainly become a part of the monitoring and evaluation program to continuously monitor and evaluate the continuity of protection provided, duration of protection provided by vaccinations. But at this point, the testing by antigen tests, I'll talk about those in a minute, and RT-PCR tests are the main modes for testing that are meant to be used for either diagnostic screening or surveillance purposes. So the rapid tests are inexpensive, but there can be problems if they're not used properly or not interpreted properly. They're inexpensive, they can return results quickly, and they can be used in both asymptomatic and symptomatic persons, but under some circumstances, negative antigen test has been inappropriately considered to be evidence that a person's not infected when they were actually symptomatic at the time of the testing, or they were a close contact, or otherwise clinically or from a public health perspective, it should have been considered that if they had a negative antigen test, it should be followed by a PCR, real-time PCR test. So here's another of the breaking news items this morning. FDA has issued a cautionary warning in a safety communication about the potential false negative results from one of the rapid reverse transcription polymerase chain reaction tests that's been created by Curative Incorporated. When the test is not used in accordance with the package instructions, what FDA advised is that it should be limited to use in people who've had symptoms for 14 days or less, and that providers should consider retesting the patients using a different test if you suspect that the inaccurate result was given recently by the use of that test. And again, the links for that FDA warning are in the presentation. But antigen testing can be used in a systematic fashion with appropriate attention to the manufacturer's guidance. Number 5, how am I doing, Christy, on time?
You're good. You have another 10 minutes or so.
Okay, I'm going to try and move a little more quickly. So number 5 out of the 10 interventions, prompt case intervention, investigation, and contact tracing to identify, and then to identify cases, to quarantine, isolate cases, quarantine close contacts, and test the close contacts. And again, evidence and information shows us that this is a traditional public health methodology. Dr. Frieden, the former director of CDC, one of my heroes, has clearly described how you could box in the pandemic by appropriately using this approach. Of course, now that we're in surge mode and public health professionals are incredibly busy, as are clinical professionals, our ability to carry out the case investigation and contact tracing, which can be so effective, as illustrated here, when you can identify people who are infected and prevent them from exposing other people. But at the present time, well, household contacts are particularly high risk for people to get infected. And there's been efforts during the surge to reduce the quarantine period for healthcare providers, for example, when staffing ability is limited. I'm not going to go into a lot of detail about that, but CDC still recommends a 14-day period of quarantine, but has provided some guidance on reducing that. Oh, you know what? Maybe I need to shut down my. Oh,
I'll take this opportunity to share that I ordered some I got vaccinated stickers that I'm going to be sharing next Tuesday with providers. And
sorry, guys. Sorry. My lawn guy was doing the workout here. Can I continue? So, am I still on?
You still are.
Okay, so number 6, safeguarding people most at risk for the infection and for severe illness or death. A number of modalities are now available therapeutically, but also operationally to try to address this problem. We've seen very clearly that minority groups and the elderly are particularly at risk, and some people in certain occupations are particularly at risk for becoming infected. The evidence from the hospital studies is that there are sequelae to infection, especially among elderly people and people with a pre-existing complicated disease, obesity, heart and lung, and other diseases can lead to the need for readmission after hospitalizations or for prolonged sequelae. Get your flu vaccine, and everyone should get a flu vaccine because the combination of the presence of the COVID disease and influenza is not a good thing. So some of those modalities that can help reduce the risk for hospitalization in the early stages of infection include the use of monoclonal antibodies, and I'll use the royal we learned a lot about the role that dexamethasone can play, and that remdesivir and combinations of remdesivir and dexamethasone can play. So I'm not going to spend a lot of time on this, but it's clear that there are ways to try to reduce the likelihood to progress to severity and death in people who are particularly vulnerable, has been learned through experience. So we're now in a surge period. I mentioned earlier the breaking news that the Surgeon General, the Director of Public Health in California, Dr. Aragon, has issued an order to try to address this problem. And we're now in crisis care mode in a number of different parts of the state, especially southern parts of California. And there's efforts to try to make use of the guidance on reducing non-essential surgical procedures in order to free up beds for urgent needs. Again, I'm not going to spend a lot of time on this, but you can look at these results. Okay, protecting essential workers. Who's essential? Oh boy. There have been guidelines developed to establish what types of job descriptions represent essential critical infrastructure in the workforce. And those guidances have been used by the ACIP and the Centers for Disease Control, the National Academy of Sciences, NIH, and others to apply equity considerations as well as vulnerability considerations in determining the phasing of the giving of vaccines and decision making about protecting workers from infection. A number of strategies to mitigate the personnel shortages that are occurring as a result of the pandemic, shortages in public health infrastructure, which have come about, as well as funding shortages over the last 4 years and longer. are causing problems. I mentioned earlier that doing the case investigation, contact tracing work is now becoming less of a priority than getting people vaccinated. Be ideal if the two things could go on together, but that's going to be difficult. Okay, number 8, postponing travel. Sorry guys, I actually have something like $7,000 or $8,000 invested in a trip that the triplets and I were supposed to take to New York when was it? I don't remember, but I'm hoping that someday I'm going to be able to make use of those reservations. But right now, folks, if you don't have to travel, don't do it. Does infection occur in flights, in the air flights? There's at least one study using genomic methodologies to make it very clear that in fact the transmission did occur during the flight rather than before or after the flight. So airplanes can represent, air flight can represent a source of transmission. Epidemiologic studies in order to document that have been done in several other settings, but at least one, this one that's on the screen now, was done with genomic testing. Others, 2 previous reports of probable in-flight transmission did not include genetic evidence. 9, increased room air ventilation, enhanced hand hygiene, cleaning and disinfection. It works, folks. It's an airborne disease, but those viral particles can persist when you are shaking hands rather than touching elbows with friends, when you're in close contact, and it is possible that the virus can be transmitted if hand hygiene is not used properly. And finally, number 10, what about those vaccines? We now have 2 vaccines that are being implemented and allocated throughout the country and the state, and shortly there'll be several others. The 2 that have been implemented, the Pfizer vaccine and Moderna vaccine, are safe and effective, very effective, but they're only effective if they get into the arms of people. And we don't yet know how long they're going to be effective, but one hopes that they will be effective at least during annual periods of time. Maybe we're going to have COVID vaccinations every year like we do with influenza. This is the scheme for Butte County right now. We're now vaccinating in phases 1A, phase 1A tier 1, phase 1A tier 2, and phase 1A tier 3. And soon we'll be able to get into phase 1B and phase C, 1C. There's going to be a new CalVax system that will be implemented and launched in order to monitor and enable us to track and monitor and evaluate the effectiveness and continuity of effectiveness of the vaccines, and to assess whether or not resistance or variants to the vaccine, to the virus, are affecting the effectiveness of the vaccines that we have. What about adverse effects? That's another breaking news item this morning. The FDA has reported today, or I guess a couple of days ago, that there is now clear evidence in the CDC MMWR report of the occurrence of anaphylaxis, which can be a life-threatening problem. So we need to be vigilant. We need to be prepared when vaccinations are being given, because although tens of thousands of people participated in the trials, there are now hundreds of millions of people who are going to be vaccinated, and rare events will occur. So one of the questions that was asked, what are the consequences of emerging variants? The answer is that there's at least 5 consequences listed here that could be serious, the most serious of which is that a variant could evade the natural or the vaccine-induced immunity. But We don't yet have, I'm using the royal we here, there's not enough evidence right now about the whether the variants will spread more quickly, whether they were going to be causing either more mild or more severe disease. There are individual cases and increasing numbers of case reports on these topics, but whether the variants will evade the detection by diagnostic tests that we have, not so clear. And what about susceptibility to the therapeutic agents like monoclonal antibodies? Again, not so clear. More questions than there are answers on this question. Reinfection. It does occur. It's rare, but it does occur. And there are criteria that CDC has established for making decisions about whether to submit samples for evaluating the potential for reinfection. And this will certainly be important as the vaccines become more and more distributed. I think that's all I want to say at this point. Persistent positive infections as contrasted with reinfection does occur. Evidence that that effect has been gathered. Hopefully some of this is going to be addressed by the vaccine. So I need to leave at least a couple minutes for questions. Thanks so much for your attention.
Thank you. If anybody wants to ask a question, unmute yourself or chat it in and we'll announce it.
So Christy, since nobody jumped, oh, Mandy was about to, sorry. I'll jump in real fast. First of all, Bob, thank you, because I mean, a lot of this information is stuff that we know, but over time, there's so much misinformation that kind of reinforcing the science is helpful. So I appreciate that. Thank you. I wanted to I guess not ask a question, but well, it might lead to an answer though. So I see 4 things in our effort to try to get people vaccinated that are impediments, some of which we may be able to do something about and some we may not. The first one was the 15-minute observation time that you just spoke to. When we vaccinate people with influenza, about 1.3 in every million people vaccinated has an anaphylactic reaction. I don't know if it's higher or lower in this, but with flu vaccine, even though they always recommend a 15-minute observation with everything for legal reasons, the truth of the matter is that drive-through clinics, and there are many ways to get people vaccinated faster. And that 15-minute observation time is a major impediment to us getting large numbers of people vaccinated. So somebody needs to be thinking about that trade-off and decide whether that trade-off is one in the public's best interest or whether it's all about legalities and liability. The second thing I would say is that requiring us to enter it into care within 24 hours is a major impediment. Right now, that means we schedule them. When we move to the greater population, we will not be able to schedule everyone. It's way too much work. So we will have to have a way to speed that along with a paper process or something else so that we can do it quickly. All of the prioritization that we're required to do, and at this point is necessary, slows us down and requires us to schedule. And the last one is money. I know that you guys aren't getting funded for this. Enlo in particular is not getting funded for all of the work they're doing for the community right now to vaccinate. They're doing it on their own dime with their own staff. And I know you guys don't have any great way to deal with that, but that federal bill that was passed that put a lot of money out there, I know you'll be at the state, and hopefully you can be advocating for us closer to the front line on all of those issues to the extent it's possible. So sorry to take your question time with a diatribe, but you need to know what's actually getting in the way of us getting vaccine into people's arms. And those are the things. Thanks, Bob. Thanks again.
Yep, thanks so much. So 4 things: 15 minutes monitoring and evaluation through the paperwork, the phasing, and the money. So the 15 minutes and the monitoring and evaluation go together. If we don't have data. One, in the nature of the demographics of the individuals and the experience that they have when they get vaccinated, we won't be able to answer the question.
Bob, let me make sure I was clear. I probably wasn't. I'm okay with collecting the data. The requirement to have it in care within 24 hours is the part that is difficult. Without some army of people that we can hand a piece of paper to put that into care. Other than that, we can't do it without using our scheduling system. So that's the not collecting the data. I understand. I'm all for collecting the data.
Yep, understood. I don't have an immediate answer for that. We get help from the state, staffing help from the state. But one of the things I mentioned earlier is, and you know this very well, Andy, is that the funding of public health, the staffing of public health is a problem. We don't have the hands on deck. So thanks so much for mentioning those 4 things. To the extent that I can do something about it, I will certainly mention it to those CCLO folks. And Tomas, who's now our public health director, he knows these things very well. Can he do something about it? We'll see.
Yeah, who knows? I'm just, you're our voice sometimes at the state, so I'm using you in that way, and I appreciate it. I'm not looking for you to solve it. Thanks, Bob.
Okay. Others?
Yeah, this is Mandy Robertson. So I just wanted to give some feedback to the site. So for our patients that are coming in and I'm counseling them about getting the COVID vaccine, I'm sending them to the buttecounty.net site, asking them to click on the COVID-19 information link, telling them they can click on that vaccine button. But what you showed on the slide and what we see is a little bit different. It does now mention about the check mark indicates the groups that the vaccine are currently available to. Unchecked boxes indicates groups that do not have access to the vaccine yet. But then it leaves out, what do they need to do? So I'm telling them to just regularly check this site as to how somebody will be able to get scheduled or get the vaccine or what to do next, because that's a lot of questions our patients have.
Yep.
Is how am I going to sign up, or where do I go? And I'm just telling them to check this site. So just make sure there's information there, because I'm sending everybody to this site.
Thanks a lot for mentioning that. Just yesterday, some other breaking news things. And I think one of the slides mentioned this, the CDPH is going to come out with some tools and systems to facilitate more rapidly information about eligibility and to facilitate providers getting enrolled. Right now, if you were to ask your primary care provider if they would sign up, they have to be invited to sign up. And the process is not as fast or as comprehensive as one would like, but it's getting better, I hope. Thanks for asking that.
I have a question. This is Joe Matthews, retired surgeon. And what I'm seeing around town is that a large number of people, especially, I'm involved in OLLI, which is OSHA Lifelong Learning, and they don't have a clue what's going on, and there's no information getting out to them. They're sort of the voice of the community, and they hear nothing. And then I also have a sister who's in one of the care centers, which you mentioned, and 5 of the patients went to the hospital within the last 48 hours. What I need to know is, when are they going to start the vaccinations in those facilities, and who's going to do it?
Well, okay, so in Butte County, we are diligently and working as hard as we can with those facilities and our partners at Enlo, for example, and Orville, to enable those facilities to get either the therapeutics like the monoclonal antibodies when they're in the people are in the early stages of disease, or to get vaccinated. And so those are priorities. Those are 1A tier 1 priorities, and we are working to get those folks vaccinated. The other thing is, we've now I forget what the acronym stands for, IHSS, the individuals who go to homes to provide care. We're wanting to get them vaccinated because they're potentially at risk in those settings, as are the people that they're caring for, homebound people. But thanks for asking the question. We're working as hard as we can to get those folks.
Bob, can I clarify?
Let me,
Yeah.
before we clarify that, one other thing is, what is going to be the protocol for those people that are COVID positive, have no symptoms? Are they going to be vaccinated in those rest homes?
COVID positive, yeah. People who are COVID positive, according to the CDC, ACIP recommendations, should still get vaccinated. Depends to a certain extent, possibly on the timing of their infection, but there isn't any reason at the present time that anyone knows about for not vaccinating someone who's had a previous infection. Whether they're currently infected and symptomatic, that might be I'd have to look at the protocol again, but I think that might be a contraindication in the symptomatic period. Andy, you were going to ask another question?
Yeah, so I just wanted to clarify that so the people in long-term care facilities and skilled nursing facilities and the staff, they are all supposed to be vaccinated through the federal agreement, I think federal, maybe state agreement with the commercial pharmacies, as opposed to the other mechanism, which is through the hospitals so far. Do you know, Bob, has that started with the commercial pharmacies?
I don't have today's information on that, but
Okay.
Both CVS and Walmart, of course, are partners with the federal government to do that work. And I don't want to talk out of line, but I think that they're going to be doing that work shortly if they haven't already begun to do it. But you're right. Thanks for bringing that up.
Yeah, and just like you said, Bob, the CDC has guidelines for people that have been infected, and just like Dr. Bernstein said, essentially, as soon as you meet the criteria to be out of isolation, you can be immunized.
Hey, now I've gotten halfway through the immunization process, and I have one more shot on the 22nd, and would like to volunteer to help with the shots. And I know that there are probably other people that want to do the same things once they're protected. I don't know how good the protection is. From what I'm understanding, that you can still get COVID, just you won't have the horrible symptoms that you have that land up in a hospital. So what I wanted to know is, one, is there going to be, like the Butte-Glenn Medical Society, are they going to be putting out feelers for people that can help? And then two, is what is the protection that they're going to get once they've been fully immunized? I know it's 95% and there's still a 5% risk, but yeah, what I understand is even if you get COVID,
So
you won't have a severe pulmonary problems that they're having.
Yeah. So Dr. Mathis, on your first question, the answer is that CDPH is going to be making the process of getting enrolled more quickly in place, so that people like yourself who want to get enrolled, there'll be a mechanism to get that done. And secondly, on the question of protection about transmission, what the evidence from the trials says is that you're protected from the illness, the disease, and especially the severity and fatal outcomes of the disease. But whether you're whether getting immunized, getting vaccinated is going to reduce transmission is still under investigation. So, like I said, there are numerous questions that are still out there that are going to require vigilance and attention.
Is the immunization going to be able to help with the variants that are now showing up with COVID?
Wish I could offer you a Nobel Prize on that one, but that's, again, it's another question that is certainly under investigation from the CDC point of view. You know, I gave the 10 interventions that CDC mentioned in the MMWR. There's actually an 11th, which is applied epidemiology and public health investigations in order to address the questions, the kind of questions that you good questions that you and Andy and others are asking. And to do that kind of work, funding and personnel are needed, and everybody's up to there with work and the dollar sign that Andy asked about. We'll see what happens when President Biden comes in place.
So this is Ted Zwerling. I just wanted to make sure I heard what you said correctly, Dr. Bernstein, that if you've had COVID, you can still at least remain PCR positive, but those viral particles are not typically infectious to other individuals. But there are no data from the immunization studies whether or not you shed virus and what their infectivity is. Is that correct?
That's my understanding, that as far as the protective effect of the vaccine on reducing transmission, that's yet to be clarified.
Okay. The other thing that I wanted to ask, since there's some feeling that the reactions, the anaphylactic reactions or others are being caused by the PEG component. There are patients who get pegylated drugs like asparaginase or Doxil. Is there any kind of other precautions that need to be taken, especially if they've had COVID and they may be immune? Just as an example, not specifically on that, but there was at the CDPH Cahan call yesterday, there was somebody who asked a question about someone who had Bell's palsy and then got vaccinated and had some mild facial numbness. Are there groups that we should start thinking about maybe not doing something like that if they're immune?
Another couple of good questions. On the question about adverse effects and anaphylaxis in particular, I myself, the two breaking news items this morning are relevant to that. I haven't had a chance to look at the anaphylaxis report, just the title of it and the abstract on it. So there's probably some information in there that's certainly worth looking at. Again, because we're going to be doing hundreds of millions of these vaccinations and we only did tens of thousands, there are going to be effects that will occur that have not yet been identified. The other question on the Bell's palsy and so forth, I don't have an answer for that. I don't know the answer to that.
Thank you. With the PEG, it's also not clear if it's an antibody-mediated response or some alternative pathway. But the question would be, so many people have gotten Miralax, so there's probably a lot of folks out there with antibodies, and if PEG's important, it was just an observation. Thank you.
You know,
my guess is that at least there would be some indication of that from the tens of thousands of people in the trial, but maybe not.
So not scientific at all, but anecdotally, we've immunized about 3,000 people. We've had one vasovagal episode. I've had a couple of people describe a PEG reaction from when they got a colonoscopy, and rashes, and those people have gotten this vaccine and done fine. Now, that's just anecdotal, but it's what we've seen locally.
One last thing on my side, and that is one of the challenges I mentioned is vaccine hesitancy and the related problem of literacy, health literacy, depending on what sources of information people have. And I see this as a really serious problem that I understand. The other day I had a squamous cell carcinoma removed from my wrist, and I was told that providers in that particular facility, maybe 30 or 40% or more of them, are not wanting to get vaccinated with COVID. So there's resistance out there, and if we're going to be successful in the vaccination program for COVID, we need to get to 80% or so coverage. And if we're going to be successful in preventing another measles outbreak in California, Andy, you and I know we just need to get our population interested in immunization. So, Christy, what do you think?
Dr. Katras has a question.
Yes, can you hear me?
Yes.
My
I can't
question is
hear very
this.
well.
My question is this, when you do the rapid COVID test and it's negative, should you be doing the COVID PCR test?
If you're doing it in accordance with the the package instructions, you should ideally you should be doing it with symptomatic individuals. If you're doing it with asymptomatic individuals, if you're doing it with symptomatic individuals and it's negative, you definitely need to follow it with a RT-PCR. If you're doing it as a screening method, and you're doing it with negative individuals to screen and get early indications of infection, you need to think carefully about the individual, the population of which that individual is a member, whether or not a negative test in that population is meaningful or not. I would encourage you to take a look at some of the links when Christy distributes the presentation.
And the other question I have is, if a patient has symptoms, viral type symptoms, and let's pretend viral symptoms, and they're and they get, they're COVID, then they become asymptomatic in less than 14 days. Should we still be saying 14 days? You need to quarantine. Do not. What should we be telling patients?
I'm not sure you were distinguishing between the individual who was infected or the close contacts of that individual who have been exposed and may be incubating an infection. The guidelines are that a 14-day period of quarantine is what's recommended by CDC. They've come up with some options to reduce that period of quarantine to either 10 or 7 days, depending on the symptoms of the individual and the test results of that individual. And we just encourage you to have a look at the materials that are in the presentation that I sent.
The problem is the 7-day and the 10-day. It mixes. It's very. I've looked at that and I'm all mixed up. I really, because the 10 days and the 7.
Those are meant to be considered as options under circumstances where, for example, critical workforce individuals want or needed back at work. CDC still makes it very clear that 14 days is the recommended period of quarantine.
Okay, so those new guidelines, when you say critical, I'm thinking medical profession then, not because definition was, everyone thinks they're critical, but I mean, let's be honest, we're probably talking about the medical profession, correct?
Yes, medical professionals, but it could be, say, law enforcement personnel who are like staff in a prison or a jail. Or people who are, there's a definition of essential workforce, critical workforce that's been developed, by, I've forgotten the acronym, the name of the acronym stands for, but there is such a thing as a critical workforce, and there may be circumstances during the surge when the personnel needed to carry out a critical function in society or in quarantine. And if they can adhere to the 10-day or the 7-day option recommendations with testing and so forth, then they would be permitted to exit quarantine.
Thank you. Thank you very much.
Thanks for your question.
Okay, are there any more questions?
I
Yeah,
would
this
make
Carter,
one
sorry, I didn't unmute. Can I ask a question real quick?
Mr. Carter?
Oh, But go ahead if you have a question.
Hey, James. Just real quick, I wanted to give a shout out that is it Catherine Newell is going to be doing a presentation on, I think, the 13th for CMA, or maybe covering a lot of the same topics. And I would encourage folks to sign up for that and put those same questions there.
I think it's on the 19th, but yeah, I do
19th,
have to
is it?
send that out. It's at least a week away.
Okay, James.
Yeah, thanks. Other than people with isolated, symptomatic people with COVID, other than isolated anosmia or dysgeusia, what percentage, do we know what percentage have a cough?
The range of symptoms, including gastrointestinal symptoms that could be mistaken for, some just food-related stuff or whatever. The range of symptoms is huge. And in the context of the flu season, I think that you got to use clinical judgment and information about the person's circumstances, work circumstances, travel circumstances, etc. Testing is probably a good idea.
Okay, thanks.
One other question, this has to do with the community. When I go out in the community and say we're going to get something, I still see a lot of people that don't wear masks into the buildings. Is there anything that you can do about that? Or is there supposed to be like a hotline that you say, I know that everybody who goes in the building is supposed to be wearing a mask and they're not. And I know that there's no enforcement that is going on. But
Right. Well, this is
facilities still stay open.
This is a challenge, like the vaccine hesitancy challenge and the health literacy challenge. People's sources of information, their beliefs and attitudes and so forth are sometimes often contrary to what the science and the evidence and information is. But as far as enforcement is concerned, of course, you're welcome to, as a citizen, you're welcome to report that information to what's the California the Consumers Reporting Agency. You're welcome to report it to whomever you wish. But our experience so far is that partners that we might otherwise depend on to enforce the non-pharmaceutical interventions are busy with a lot of other stuff and don't see that work as a priority. It is not a public health department function to enforce those.
Yeah, the biggest problem I see is that these communities where the business owner wants to have everybody with masks and say, you cannot come into the facility without a mask, and they're still doing it, but they have no way of shutting it down other than to just close their doors.
Well, there's that. I mean, they could refuse entry to somebody, but there's also the fact that one business owner who's adhering to those principles and a competitive owner who's not, they're looking at each other and saying, I'm losing my employees, I'm losing my income, I'm going to go and I'm just going to do this. And that's something that is unfortunately not in the interest of the public welfare.
Yeah, the biggest
there are ways to try to manage a restaurant, for example, by having takeout functions.
Right.
So it's
right. And in fact, this facility does have takeout, and I keep thinking, well, if the people would just stay outside and they could bring their stuff out there, it would protect the people that are doing the right things of wearing a mask. But one thing also is that if the employee says, no, you need to wear a mask, people get angry. And we're starting to see, I don't know if it's the virus fatigue or if it's just, I'm a Republican or whatever excuse they want to use. They get angry back at the employee, which it's not their fault. They're trying to protect everybody.
Yeah. These are difficult times. better times, I think, are ahead after January 20th.
Yeah, I hope so. I don't know, they're riding on the Capitol steps right now. So.
Yeah.
Jim Schlund here. I want to first thank you for the update. It was timely and very thoughtful and well done. The news out of Los Angeles in the last couple of days has been disturbing. And in the concern of the rising tides of this pandemic, where large metropolitan areas can no longer accept transfers from other outside adjacent communities, there's going to be this ongoing high watermark that moves towards even us. What's it look like, Andy? Any thoughts? What are we seeing out there?
I'm glad you asked Andy.
I was going to say, I'll let Bob do it. I don't see the county or state numbers any
I'm
longer.
leaving.
I'll just say this. I'll say that, Enlo administration is seeing rising numbers and taking steps and are very concerned. I can't, I'm not as involved in that as I used to be, but, and Bob would have to be the one to talk about the state or even county numbers overall, because I don't see those anymore. But I think your concern is not misplaced, Jim. I mean, it's worrisome. And, so hopefully the message, those 10 things that Bob just told us about, can really get some traction locally and everywhere.
The only other thing that was interesting of recent, just as a comment, is The Economist had an article amongst the G7 industrialized nations that Japan has done exceedingly well with this, as understandably culturally fastidious people, but they have had the lowest death rate amongst the G7. Interestingly enough, they've been doing the least amount of testing. But it's an entirely different
the most amount
culture.
the most amount of mask wearing.
Jim, do you remember early on, there was a CDC guy or maybe a World Health Organization guy who traveled to China when they just started to get it under control in China. And he basically said, my worry is that the things that they're doing here, you're never going to be able to do in the US. And he was exactly spot on correct. Exactly correct.
Right.
There are cultures where people are willing to give up some of their individual rights for a collective good. We sit somewhere else on that continuum.
Yeah, cultural shift is a giant ship with a very small rudder. It's going to take us a long time to make the cultural shifts that other people accept as part of just living in Japan. But yeah, it was interesting to look at the other national statistics.
Yeah, I had that one table with the death rates that are interesting, and I've spent 15 years in Singapore, and you can say what you like about an authoritative government, but when it's a thoughtful, evidence-oriented, authoritative government, things go really well.
I just messaged in the chat that I lived in Japan for 2 years in 1990 to 1992, and people wore masks back then if they were not well or they needed to be protected. It's part of the culture.
No, I'd go to Disneyland in the 80s and 90s, and they were wearing masks in the theme parks. So, it's true. And then the doctor, Andy, the doctor you were thinking of, maybe Dr. Brilliant, who there's some great TED Talks. And he said in 2005, we were going to have this epidemic. And he even said it's going to kill us. It's going to destroy our economy if we don't get a hold of it. And the information that we had came out back in December. And he said, we knew about this in December, but he said he did it through a Canadian group. And the Canadian group has been reading the newspapers and listening to blogs in about 12 different languages. And they knew that this was coming about, and it was just being suppressed. And obviously we've had, I think it was Woodward who came out and said, yeah, Trump told me about this back in January and said we're just going to keep it away from everybody.
Yeah, Larry Brilliant and Lori Garrett.
Yeah.
If you look at their publications, there's some really good stuff there.
Yeah.
I'm taking a lot of time from people. I don't know, we can go on with this. I'm happy to do that. But, Christy, what do you think?
It's therapy.
It
You
is.
know,
It's good
I've
to
been
see
thinking,
everybody.
like, well, we'll do this one virtual grand round, kick off the new year. It couldn't have been better timed, and also oddly poorly timed with what's going on in DC. But I feel like we need to continue doing this maybe on a monthly basis, Dr. Bernstein, just to like keep the dialogue going. It just feels like there's so much information changing as well. And how can CMA, like at the state level, activate to help us locally? I mean, so lots more to talk about if we want to do this more frequently.
Yeah, I think probably ought to have an emergency room doc or an ICU person next time, maybe.
And then how do we get a hold of your slides? Is that going to be coming to our email addresses or how?
The slides are about 15 megabytes, but there's a PDF version that's about 6. And I'm going to send both to, I'll make both available to Christy. And if there's a way to place the larger one on a website or something, that would work. There's mechanisms to do that, but my kids probably know how to do it.
I can put it on the Butte-Glenn Medical Society one. I don't know how to link the YouTube, but I'll figure it out somehow.
Okay.
Can I ask you a scheduling question? I belong to a group that had made arrangements to have you do a presentation tomorrow, RPEA, Retired Public Employees Association.
Yes,
I'd
correct.
heard the program chair of that yesterday that she'd not heard back from you yet. Are you still planning to do that, or what's the status?
Yes, and I apologize. I haven't said anything to them, but I am. I guess I'm waiting to find out how I get logged on. And
Okay. I will relay that information to the program chair, Betsy, with whom you've spoken, I guess, in the past, and let her know that you're preparing to do that. You just need to get information about the technology of it, and I'll let her know that.
Right, and thanks so much for bringing that up. Can I ask one more thing?
Sure.
Can I give you my personal email address, because I'd probably be doing it in the evening, and I'd want to do it that way?
Sure, that'd be
So
great.
I'm going to say it, then I'll spell it. It's troikadad@gmail. It's spelled TROIKADAD @gmail. A troika is what the Russians call a group of 3. So I've got triplets.
Okay. Gmail. Okay. troikadad@gmail.com.
Yep.
Well, thank you for confirming that. The group is looking forward very much to hearing your presentation.
And sorry to take the time, but can I just ask how much of, or in what way should I be different than what we did this time?
I think much less technical data. Oh, hi, Andrew. Oh, you can do much less. This is a much less technical data. This is a group of retired folks. Many are from the campus, retired university professors of large range of departments. Some of them are county retired, some are city folks, and they're not. None of them have particularly medical backgrounds or experience, so they're more interested in the kind of things that you might generally say to a general population.